So today, what we were going to be talking about is our new study that's open and currently enrolling, which is a study looking at the drug that they nicknamed TPOXX, and looking at it in adults and in children. So I wanted to, just go through a brief outline for tonight. So I borrowed some slides from Rachel. We're going to go through some epidemiology, and then I'm going to talk about the study, the STOMP study. We were going to be looking at another study, but we're no longer going to be doing that study. And so I wanted you all to just realize that if you were reading the emails and are expecting a second study, that second study is no longer going to be done by us. But I do have 3 questions, which we'll see how it goes with the people that we have, because we wanted to get some of the opinions of people around these things. So let's get started. Rachel, I didn't know if you wanted to talk through these slides of the epidemiology or if you wanted me to.
I'm happy to, if you would like to.
If you want to, that would be great, because I feel like you would have a better handle on it.
Sure. So the numbers that are on these slides, I think, are probably about a week or 2 out of date. So I apologize for that. I'm actually planning on updating them for a talk I'm giving on Thursday.
Oh, wow.
So this is data from the WHO. So this is global data, and it was presented at IAS.
Mm-hmm.
So this is already, again, so this is not the total number of cases that exists. The total number of cases in the world is somewhere around 65,000, I believe, right now. So this is just data on 11,000 of the first 13,000 cases in which they had laboratory confirmation. The vast majority of these cases, as we now know, globally are in the same demographics we're seeing here in Seattle. So mainly men, and mainly men who have sex with men. And then in the United States, we're also seeing people assigned male at birth who don't identify as male, but who have sex with men. So that's the predominant group that we're seeing, MSM and gender diverse people who have sex with men.
Okay.
And then healthcare workers globally, I don't know so far of any transmissions in the healthcare setting in the United States, probably because we know this exists and PPE is available. It's thought that the primary mode of acquisition is during sex. And I will say during sex rather than sexual transmission, because there's a lot of questions about how much of it is actually sort of as a result of transmission of bodily fluids during sex in what we usually call like a sexually transmitted infection, versus that generally people are right up next to each other with a large portion of their body with not so much clothes on during the act. So there has been non-sexual transmission, definitely, but in most of those cases, it's close skin to skin contact, including that there's been common exposure settings, again, among, like, I think some of the first cases in the UK were in big parties. They were in sort of LGBTQ parties, and they're parties in which there's a lot of skin and not a lot of room. So again, the kind of the common theme is close contact. And we haven't seen, I think, a lot of what people were really initially worried about was, like, if you're on the bus with somebody who has monkeypox, or you're in school, like, are you going to get a secondary transmission? And even though there is purported respiratory transmission through droplets and maybe via aerosols, it really seems that the majority of these is 2 people with not much clothes on, pushed up next to each other in a non-sexual or sexual context.
Could I ask a question about that? So, for instance, we don't have any data yet on people who might be roommates who have, like, had it, like, spread that way, even like sort of anecdotal stories. Do you know what I mean? Like, have people, like, there are in a situation?
Yeah, absolutely. I know of in Seattle a scenario in which that happened with non-sexual contacts with roommates and people who don't share a bed. But there is theoretical transmission through, like, laundry or bed sheets, because the scabs are infectious. And then people who've had sort of intimate contact in the sense of, like, caregiving of someone who's ill. So not necessarily I don't know about people who are like roommates who don't have any other, like aren't sharing a bed or have any other contact, but like caregivers, family members, or other things. And actually, the very first case is a really interesting story. It's worth a read on NPR about the Nigerian physician who diagnosed like the first 200 cases of this back in 2017, and who the government kept saying like, shh, this is not happening, pretty much. And part of the story was an 11-year-old boy, and it was then later sort of discovered, they thought that he was playing with wildlife, and it turns out that actually he was a household contact of a male who had presumably had transactional sex, and that there was potentially kind of an outbreak ongoing amongst young men and among, I think, cis female sex workers in this area. But because this was sort of so taboo to talk about it as being sexually transmitted, because that's not how monkeypox spread, as the like dogma went, that the Nigerian government sort of said, you know, like, let's keep wraps on this. And it, unfortunately, I think really delayed recognition of this as a national and international event of public health importance, and increased the stigma tremendously, and the care that people were getting. So that's kind of a lot of the backstory.
And
symptoms.
I wanted to ask one other question, and this is a little bit about transmission, but what about transmitting it to pets? I know I've heard that can happen, but
yeah, somebody's greyhound got it.
Okay.
Dogs, I don't know about cats.
I heard dogs, cats, rodents.
Rodents for sure. Rodents are actually the primary reservoir. So part of what's been really, really confusing about this disease is that while it does have a host in monkeys, in non-human primates, it's not the primary reservoir. And it's actually more in giant Gambian rats and other rodents.
Wow.
So monkeypox is a misnomer. Monkeypox is stigmatizing, and then doesn't even really describe it anyways. And then to make things further more confusing, I've heard a number of patients, especially Spanish-speaking patients, who refer to it as chicken pox. So I've had people come in who have monkeypox who keep saying my chicken pox, my chicken pox.
Wow.
And so it's two animals, none of which really have nothing to do with either of the infections that are going on.
Well, thanks for that.
Yeah, no, sorry. Yeah, please, like, I'm totally happy to like debunk whatever things are coming up. So the predominant thing that we're seeing is rash. There's some really interesting sort of data from a genomic standpoint that it seems like this virus mutated at the time point that we think it jumped into the human population in 2017, and it hasn't really mutated so much since. So part of the difference in what we're seeing with this pandemic is not only that it sort of, once it started spreading amongst social and sexual networks, it's predominantly spreading in that population. Again, not because gay people are more susceptible. That's another thing I want to make sure that we really debunk here, right? There's nothing about the susceptibility to it. It's about who you're touching. And you're presumably touching people who are in similar social and sexual networks as you are. But also that it seems to be that this virus, when it made this jump into the human population, adapted to the immune system in a way that's different and became much more transmissible than other prior strains of monkeypox. And something that we don't, go ahead, Anne.
No, can I just ask, is that the difference between the monkeypox of old that, you know, there are occasional cases, and the monkeypox of new?
Yeah, that we think that it kind of mutated in association to this human protein called ApoBec, which you guys may have heard a lot about.
In the brain,
like
isn't
HIV.
it?
No, it's like it has a lot to do with HIV immune function as well. So there's a lot of the sort of HIV cure work is looking at like ApoBec. I don't know a lot about this protein, so I won't expound on it, but it sounds like it sort of adapted to the human host response, and something about that made it more transmissible and cause more mucosal disease. So we're seeing people that, you know, presumably during sexual contact, people have mucosal contact. And during sensual, you know, non-penetrative contact have mucosal contact, but that in people presumably who never even had mucosal contact with other people, it seems that there's a lot more mucosal disease. And in some cases, like distant site mucosa, so like people who might have lesions in their nose and mouth, and it's not clear that their nose and mouth came in contact with it. So this is things that we're still trying to learn about the biology of this virus, this version of this virus, that make it very different from the sort of monkeypox of old and like the other clade of it that's currently circulating in the Democratic Republic of Congo. So this one originated, it seems like, in Nigeria, and then leapt into a population in the UK, and from there throughout Europe and now the world. So lots more genital rashes and mucosal rashes, and proctitis is a really specifically troubling component to it, in that it's proctitis meaning inflammation or infection in the anus, and it can be extremely painful, I hear.
Yes.
So, okay, go ahead and go to the next slide.
All right.
So, okay, so this is, I kind of jumped ahead about these, but so you can see this is a little bit of the difference between the two clades. So this Congo Basin clade is the sort of more like ancestral one that has been going around, and there actually was a TPOXX or tecovirimat study already ongoing since 2018.
Wow.
That was planned in part due to this, what was going on in the DRC. And you can see that the CFR, or case fatality rate, which means the number of people die of whom get it, was between 1 and 10%. So potentially 1 in 10 people was dying. And it's a small number of cases, but that was sort of this typical presentation. And almost all of these people had direct animal exposure. Whereas this 2017 to 2022 data is a much lower case fatality rate. A lot more people have HIV co-infection. And so when we talk about susceptibility, it is possible that people with HIV are more susceptible when exposed. But again, this completely disaggregating this from this sort of what people were seeing in the media about sexual identity or orientation having to do with susceptibility. So that's not true at all, of course. But potentially we're seeing in the US that about 45% of people have HIV co-infection. So we are seeing it more. And again, is that just because of sexual networks that it's spreading with and who people know? Or is that something where you can be exposed to it and not get sick? And if your immune system is robust, you're less likely to have clinical illness, but maybe somebody with HIV is more likely to have clinical illness. Maybe they're more likely to know that they should go get tested when they get sick, for example.
Right. There must be some way for them to suss that out, like to figure out, is it because of HIV or is it because of the HIV networks? And
So all this research is ongoing, for sure.
Okay, cool.
This is both lab research of like looking at people's antibodies, looking at immunities, trying to see if people are more susceptible, trying to see whether people respond better or worse to the vaccines, depending on their immune status. All of this. And then if there's a relationship to people's CD4 and other healthcare status. So that's actually a study that I'm co-leading with Nicolina Montano, who is a postdoc epidemiologist here at the UW, and it will happen through the CNIX network. So just like the data that I've presented to you guys in the past about COVID and HIV, we're doing essentially the similar kind of big epi study of all of the CFAR clinics looking at monkeypox. And one of the key things we'll look at is ART, is people's virus suppressed, how's their immune system doing, and seeing if we can see sort of any trends that help us figure out, is it susceptibility or is it just sexual networks?
That's great.
I think that, when I first read the causes, I felt this depression because it echoes so much of HIV. And I think that when people read that, they have the same, and experience. And I think that, it's amazing. You can say the same thing about COVID as well.
I have learned so much from you all about the trauma of going through a second pandemic with COVID from what I heard from everybody in 2020 and 2021. And gosh, it's happening again.
And
so I think that, you know, when people read that, they naturally go right back to gays. It's a gay population.
Yeah.
And that's the way it's coming out in the news as well. And so
Yeah.
I think that there's just no escaping that. And, um, you know, sometimes I think, you know, who cares how it's transmitted? It's being transmitted. That's the important thing.
Right. Well, there was actually like a ton of very careful thought, and I like in sort of like the Twitter circles that I am in with other people who do messaging. There's a lot of consternation about how do we talk about this virus, because it's important to tell men and non-gender conforming folks who have sex with men that they may be at increased risk because those are the networks in which it's spreading, but you also don't want to stigmatize it. And so then some people were putting out these messages that were just being like, anybody's at risk. And then you're not helping people who may actually be at risk understand how they could be at risk and how they could reduce their risk. And you're also sort of, that's, I think, part of how the mass hysteria started about it as well, is because it's like, well, can I get it at school? Can, you know, the world is ending. And it doesn't help people who have what we now know are like risk factors, which are potentially multiple sexual partners or anonymous partners, or, you know, being in hot, sweaty, confined spaces with a bunch of bodies. People could choose, oh, like, well, maybe I might choose to do other things. But if you don't actually share those risk factors and they don't know, and I think there's some really careful people, like people were trying to message this very carefully, but then some people were going way on the other side and just being like, maybe we shouldn't even talk about it. And then arguing over whether it's a sexually transmitted infection or not, or whether it just gets transmitted incidentally because people are rubbing against each other during the act.
Right.
And that kind of lost the whole, I don't know.
Yeah, well, that makes sense. So thanks for saying that.
Right. And I
think there were a lot of people very clearly trying to be very cautious about how they were saying it. And like, if you call it an STI versus you don't call it an STI, but the key thing is to tell people you can get this by being naked next to somebody or nearly naked next to somebody, right? Because then that allows people to choose, like, maybe I'll dial it back this month and like wait and see what happens. Or if I'm someone who tends to go to clubs, like maybe I'll just tone it down for a bit.
Right. Or maybe I'll get a vaccine, or like
get a vaccine, or like, could I actually decrease my risk by wearing a shirt when I might otherwise just wear jean shorts to the club? Like, I don't know. These are all things people can make choices, but they have to have the information.
And I know some people who have closer sexual networks are podding, where they're basically only agreeing to have sex within their group. Like, so there'll be 6 of them who are not necessarily in relationships, but they're in this sort of sexual relationship, and they are just exclusive to the 6 in the pod, like that. So I know, like, there's lots of things that people are doing to mitigate the risk, you know.
Rachel, can I ask a question? There was talk about a different name. What's the status of that?
I think that the WHO is still working on it and still considering it. My understanding is that there was a big push initially to do that. And then there's actually been some pushback from colleagues in Africa as well, who are like, wait, so it was okay to be monkeypox when it was, you know, poor Africans getting infected, because it was okay to sort of stigmatize this animal-human relationship. And now that it's in high-income countries among a kind of more affluent population, like all of a sudden it's not okay to be monkeypox. Right. So I think, you know, like everything, there's a lot of complexity, and I believe that the WHO is working towards potentially a new name, but there's a group of people who are sort of like, well, you know, it's had this name since 1959. And for the entire history of this virus, it's infected people who are in close proximity to nature in Central and West Africa. So like, why change now? So there's pushback even amongst people who are being affected by it. I think amongst the research community and the clinical community, we try to use the like the acronym for it. So oftentimes you'll see it abbreviated either MPV, or I think it's to have the X in there to me, because pox viruses have an X. So I think more typically it's MPXV, so monkeypox virus. And I like to use that term just because then I feel like you're identifying what the virus is and what the clinical syndrome is without having to say monkeypox.
Mhm.
But yeah, I don't know.
I would like to address as a community member from the perspective of a community member of this particular community. I think that it is rather critical and important to be aware of not further stigmatizing any particular group, especially this particular community, the HIV community people or community who are involved in this type of research, so that they are not being blown away or scared away from getting the proper information. I think that also contextualizing it in such a fashion of emphasizing what is most important by, parsing it out that way, so that the impression of further stigmatizing any group is somewhat delineated or reduced. I think that will be very helpful for presentations like this. I realize that this is an ongoing process of work in progress. At the same time, too, is that while the work is in progress, it's best to get feedbacks from those who are hearing this type of information, this type of research, so that at the same time they're informed, as well as the feedback provided to the presenter and the message to be sent out is more sophisticated in the sense of delivering the message without further stigmatizing or marginalizing further certain populations or communities. I don't know whether I'm making sense.
You are, total sense.
You're making perfect sense, Jay. If there's anything I could be doing better, please let me know. I should sort of also preface this, that this study that we're doing that has just opened through the ACTG and that we're doing it at UW Positive Research is not only in people with HIV, it's actually anybody who's been infected by monkeypox. But please do give me feedback in the moment or later if there's anything. I'm presenting slides that were these were from IAS, from the International AIDS Society meeting. That kind of gives some background on the virus, but and trying to tell the story a little bit about how it's come in the media. Again, these aren't words that I always choose to use. I'm sort of giving some of these examples in terms of debunking these. But if there's anything that I could be doing better, please do let me know.
And Jay, you should know that at least I know that King County Public Health, Seattle King County Public Health, has had meetings with basically men who have sex with men and other gendered people who have sex with men to talk about these things and to hear sort of what the public health data is and to help them sculpt those messages so it helps to take care of those concerns that people have about stigma. So I know that at least locally, it's been getting a lot of attention, and those meetings are very informative, not only from what the public health people are telling the community, but what the community is telling the public health people.
Yeah, absolutely.
While I'm very aware of that, I will answer a very specific question for you, Rachel, is contextualize the presentation for the targeted audience that will be most effective in each and every single presentation. Not that you didn't or you are not. I'm just saying that will be a very good start or a good pathway toward a clearer presentation. I'm not criticizing, I'm just making a suggestion, a comment.
Thank you so much, Jay. No, I appreciate that. I think Michael and I could probably do a better job of coordinating. I gave him some slides and I am talking through them. And we'll get right into the study as well, too. I just figured for anybody who had outstanding questions, we could talk about monkeypox in general before we move into the study. But if this feels too diffuse or people have been reading about it and feel very sort of comfortable with everything that it's sort of the general epi and what's been going on in the world, then we can kind of sail through this as well.
Right.
So with that, onward.
Oh, right. Let me get this. Go.
Okay. Okay. So again, this is as of the time of IAS, and this is good practice for me. I'm giving 2 talks in the next 2 days, and I will update these numbers. The case count is now, I think, above 65,000. So keep going forward.
Wow. Oh, you wanted me to go forward? Okay. Sorry.
Yes, please.
There you go.
I'm taking feedback and I'm staying on point. Okay. So complications in treatment. So as I mentioned, we have, I would say, a huge proportion of people present with proctitis, meaning inflammation and severe pain in the rectum. It often is associated with constipation or inability to have a bowel movement because of how painful it is. A lot of people we're seeing have cellulitis or an abscess or a bacterial superinfection, or in some cases there isn't necessarily a bacterial superinfection, but the rash itself is just so red in the area that people are worried about it. Ulcerative pharyngeal lesion, so this can look really bad. I had a patient who was referred to an ENT surgeon for a peritonsillar abscess, and in fact didn't have an abscess. It was all monkeypox.
Wow.
Eye involvement, so very serious thing. And then it can mimic other sexually transmitted infections, specifically herpes, because it's a painful ulcer, and syphilis. And we're also seeing a lot of co-infection. So we're seeing a lot of people come in with both 2 things at once. And then into the treatment, and this is where we come into the study, is that it's actually changed a little bit in the past week, what's being recommended in the United States. And I want to preface this with the US recommendations are very disparate with what's going on globally. I say this with full recognition that there's global disparities, and it actually really weighs on me quite a bit because right now, the majority of people in King County who present with monkeypox are getting treated. Whereas in other jurisdictions, people are not necessarily, and actually globally, very few people are out, I would say, in endemic regions in Nigeria and the DRC, for example, where this is considered to be more an endemic virus. There's very little access to antivirals, and they're really limited for people who have very severe disease. So people who are hospitalized, children, pregnant people, or people with neurologic or eye involvement. So here's the key thing for why we're doing this study. There is no approved treatment specifically for monkeypox. Most of the antivirals that we know or that we think work or that have been studied in animals. And that brings us to tecovirimat or TPOXX, the one that we're using in this study. So tecovirimat has FDA approval for smallpox. So smallpox and monkeypox are both orthopox viruses. They have, I think, 98 or 99% similarity in their genomes. And so tecovirimat was approved by the FDA in 2016, I believe, for smallpox. And that's why it's in the US emergency, what's the word I'm thinking of? Stock hold. It's in the emergency supply. Right. And the idea is that if somebody were to release smallpox as a bioweapon, that's what they would use this for. That said, it's actually never been studied in people against smallpox. It's been studied in people for safety. So because smallpox was eradicated in 1981, right. It was eradicated in 1981. We never got to actually test, does it work in people against smallpox? So they've given it to, prior to monkeypox, they had given it to hundreds of people to test the safety, but not against smallpox and definitely not against monkeypox. There have been some, again, small studies against monkeypox in the DRC that have been ongoing for a little while, with the most recent outbreak since 2018. And now thousands of people in the United States have received tecovirimat through the CDC program with an IND, meaning investigational new drug release. So it has sort of this compassionate use or expanded access protocol. And you may ask why it's an investigational drug under this protocol if it has fully FDA approval. And that's because it was approved for FDA use only using animal studies. So it's sort of like FDA approved with an asterisk, meaning we think it's safe in people. We haven't studied it in all types of people. For example, pregnant people, children, people with different medications that might interact with it. But in healthy people without other drugs, it seems to be safe. And it's now been given to thousands of people for monkeypox, and it seems to make it better. Seems to make it better is not data. Right. And then the other treatment that we have is either cidofovir or brincidofovir, which is a long approved antiviral that Anne has probably used way more than I have. We usually use it for CMV, sometimes for adenovirus. It also has been approved for smallpox disease, and it treats a lot of other viruses, but it's extremely toxic, and especially cidofovir. And so this is a medication, for example, we give to our transplant patients when they have a severe viral infection that nothing else will treat, but we use a lot of caution with it, and it's IV. Brincidofovir is oral, but it also sort of has some safety concerns of limited use. And then the other thing that we have in our armamentarium is post-exposure immunization. So the vaccine Jynneos that many of you have heard of and maybe some people have received is, again, also a smallpox vaccine that has animal data against monkeypox. So we know it's safe. We know it's safe in people with HIV because they actually did study it in people with HIV. And it's been tested in the military against smallpox. It seems to be a good vaccine for smallpox. We haven't tested it against monkeypox, but we now have it as both a preventative vaccine and a post-exposure immunization. So if someone knows that they've been exposed to monkeypox and is not yet sick, they can go get a dose of Jynneos. And we have seen people, actually, I've seen a number of people who've ended up with monkeypox after getting a Jynneos. Usually it's right around the time they think, I've been exposed, I should go get a vaccine, and they end up with monkeypox anyways. But so far we haven't seen people with really severe disease. So maybe it's working to some extent to lessen the disease severity, but we don't really know because we haven't studied it yet.
What is that shot that people go and get if they're in one of the at-risk groups?
Where do you get the shot? Madison Clinic. The shot is Jynneos. It's the Jynneos. It's a non-replication competent Vaccinia Ankara, modified Vaccinia Ankara vaccine. So Vaccinia is cowpox. So we're adding another animal pox to the story about this. Cowpox is what's in the original smallpox virus or vaccine. So if any of you are older and you received a smallpox vaccine in your youth, you received a live smallpox virus vaccine that probably caused a nasty smallpox lesion on your arm. And that vaccine is not considered to be safe for people who are immunocompromised because it's actually live, replication competent, but attenuated virus. And the military still gives that to people, or they did until recently. Jynneos, on the other hand, uses a live but non-replication competent, meaning it can't reproduce itself, cowpox virus. And it's very safe in people who are immunocompromised, and that fact has been tested prior to the monkeypox outbreak. So anybody who thinks that they should get it, either for pre-exposure prophylaxis or post-exposure prophylaxis, you should not be worried about your immune status. And thousands and thousands of people who are living with HIV have been given this vaccine now, and we have not seen anybody develop monkeypox from the vaccine. So that's one thing to say. And then another thing that's important to know is that I've had actually people ask me, I tested positive for monkeypox after I got the vaccine. Could it just be the vaccine that's causing me to test positive? And the answer is no, because people test positive for monkeypox virus from a lesion, and the vaccine doesn't even have monkeypox in it. The vaccine, again, is an attenuated cowpox.
Right. And Bill, let me add, if you are interested in getting the vaccine, it's very easy to do. The sexual health clinic, which is over there in the 9th and Jefferson building, that 13-story building on the 11th floor, you don't even really get to go into the the clinic because they have it set up in the hallway there where you fill out some paperwork and you can get your shot. It took about 10 minutes total. So if you're concerned or if you're thinking about that, that's where you can get it.
Oh, I'm not concerned for me. I was
Okay.
just thinking.
Oh, yeah, no, I was just saying if it's also good, I think, for all of us to know these things. So when you hear someone talking about it, you can tell someone how easy it is and like, you know, where they can get it.
I was responding to that part of the slide that said there is no treatment.
Right.
And does this vaccination prevent monkeypox? Or can you still get monkeypox even though you get vaccinated?
If you're talking, Rachel, you broke up.
We're not hearing you.
We can't hear you. I don't understand because we could before.
Yeah, I know. I don't know what.
Oh, now it looks like you're on mute.
Oh, yes.
According to the.
Can you guys hear me now?
Yes.
Okay, I think what was happening is that my earbuds were just dying. Sorry about that.
Before Rachel, may I please interrupt? I would like to predicate a statement to what Michael just said about the 11th floor of 9th and Jefferson building. That particular site I went to is for a certain age group, which is a very young age group. I think that is between 30 and 39 years old. But that was a week ago when I went. That may have changed. May we all verify the assumptions before we conclude? Otherwise, maybe running into some hurdles. That's all I want to say to that.
So Jay, I believe what you're referring to is the study. So they're actually conducting a vaccine study out in the hall. And I believe you can still get Jynneos inside the clinic. So I think there's two different options for how to get it. And I believe that the age limitation is only to participate in this study. But I'm also happy to confirm and feedback the information. I was also saying anybody who's a Madison Clinic patient can get it at Madison. And at a doctor's appointment, you can just ask for it. Every patient that I see, I ask, do you think these are the risk criteria? Do you think you're at risk? People don't have to tell me what their business is up to. I can just say, this is who we're recommending it for. Do you think this applies to you? And people say, yep, sign me up. And they get it right there. Important things to know about this vaccine. We're now giving it intradermally, which means it kind of looks like a PPD test. It goes on either on the inside of your forearm or on the inside of your upper arm. And it causes a red spot, and in some cases a red streak and a big red patch that can last for quite a while. In some cases more than a week or 2 weeks.
Mine's lasted 4.
Yours is 4. You're going on 4. Yeah, I'm hearing people have 4 or 6 weeks of this. In some cases they're itchy. They are not cellulitis. They don't need antibiotics. I think that's a robust immune response. I don't know that it has to do with someone's underlying immune status. Somebody also asked me if it had to do with having been exposed to monkeypox before, like the way a PPD test turns positive if you've been exposed to TB. I don't think that's the case because lots of people who we don't think have been exposed to monkeypox are having these very robust reactions. But just to let folks know, just so that you're prepared if you end up getting it. The vaccine efficacy, meaning the percent of infections that it prevents, is not 100%. And what's making it a little bit difficult to understand right now, the vaccine efficacy, again, is we don't have studies before this, but also quite a number of people are getting vaccinated after they've been exposed. And so we always know that the efficacy of something that's given post-exposure prophylaxis, like if you already have virus replicating, is a lot lower than something that's given preventatively. And so someone who shows up with monkeypox a week after getting vaccinated was probably exposed a week or 2 weeks before they were vaccinated. And so that's a very different story. That's sort of, I would call it like a breakthrough, in which hopefully the vaccine made the infection less severe. But we don't actually know, does it prevent 80% of infections or 50% or 100%? We don't know. I would say it's not 100%, but again, most of the ones that I've been seeing are people who, by the time they got vaccinated, they'd been exposed. Okay, we're on to the trial now?
Yes,
So
we are.
I don't understand. Does the vaccination prevent monkeypox or not?
It definitely does, but we don't know to what extent. So,
Okay.
right, so when we've been talking a lot about vaccine efficacy with COVID, right? So we were talking about someone's risk of getting COVID with the original COVID strain was like 90% less than someone who hadn't been vaccinated. That means that there's still a residual risk of getting COVID. Then when you compare the vaccine against the Delta virus or the Omicron virus, it's preventing a lot fewer infections, although this new bivalent COVID booster, which hopefully everybody will get, I got last week, will prevent more infections because that one is better matched to Omicron. Okay, so we can talk, when we talk about the vaccine efficacy, it's sort of the number of people who got the infection compared to the number of people who got the infection despite being vaccinated compared to the number of people who got the infection without being vaccinated. So there's never like you get exposed, you get infection. That's never 100%. And it means that compared to a population who was not vaccinated, what proportion of infections were avoided? So we don't have that data yet. I presume it's some proportion. Did we avoid 30% of infections? Did we avoid 50% or 80%? We don't know.
Yeah, I asked that question because, when people get vaccinated, they walk out the door thinking they're protected.
Oh, yeah.
Yeah. I would say it is not a suit of armor. It's not, we made this mistake with COVID, right? People are like, oh, it's cool, we can do whatever. I'm vaccinated, right? So being vaccinated in this case, we think should make the course of illness lighter. It should prevent severe disease. It should maybe make the lesions crest faster, make it less painful. This is what we hope. And it should reduce the amount of virus that's there. So presumably someone who's been vaccinated but still got infected anyways, presumably would have less likelihood of transmitting it to other people. But we don't know what percentage that is. Like if someone is vaccinated and gets monkeypox, are they still exactly as likely to give it to their next partner? Are they half as likely? We don't know yet. So I think this is one of these get vaccinated, but also keep your brain in your, attached to your head.
Maybe I feel worse than kids.
Okay. Any other questions about monkeypox in general before we talk about the study?
Start the game with 10, 1 players.
I'm
One
hearing
player
unmuted
can't play exception splits.
Hold on. Is that
It might be you, Anne.
I'm sorry.
okay?
Okay.
You want me to, I can mute.
Yeah, that'd be good.
Any other like general monkeypox prevention treatment questions?
I don't have a question. I have a comment.
Sure.
I would like to introduce a didactical syntax presentation of an approach to this topic. In other words, reverse the approach by emphasizing the preventive portion of it, then present the facts, rather than presenting the facts first and then the rest. Just a didactic opinion. That way, it is so to speak a centripetal approach rather than centrifugal approach, which means that people won't be pushed away, but drawn to what is necessary for them to know and take action accordingly, and then backed up with the facts. That's it.
Okay. Thank you, Jay.
So really, I just put this slide together because I wanted everyone to know where the name STOMP came from, because it doesn't seem to have anything really to do with viruses or human monkeypox virus or, you know, the medicine. It was like, where did STOMP come from? So you can see like where the abbreviation, they get it from the study of how do you say this again? Tecovirimat for human monkeypox.
I think most people are calling it tecovirimat, but I've also heard people call it tecovirimat.
Right.
I guess it's a made up word and it's fine. Pronounce it however it makes
Yes,
makes you happy.
Tecovirimat.
Tecovirimat,
Yeah.
TPOXX,
STOMP.
STOMP. So STOMP is the study. I don't know. Yeah. Michael, would you like to present the study, or would you like me to continue? I'm happy either way.
If you wanted to continue, I mean, I don't mind either one. I kept this one in. I don't know if this is too clinical for people. This is one of your slides, Rachel. But I did like that it kind of emphasizes the 2-to-1 randomization. So people will be randomized to get, every 2 people will get the study drug, and then only 1 person will get the placebo. But it is a placebo-controlled study, and for that arm of the study, they're looking for 530 people, and of those 530 people, there's 100 people that they're looking to do some intensive sampling. So there's a subset of people to get that. There is another arm, which is the open label arm, and this is for people like children or people who are pregnant or who have severe disease or who have severe immune suppression or severe skin disease. They would not be able to be randomized. They would just go into this open label where they're going to get the medicine. So I think that's one of the biggest things for people to understand, that this is trying to do the type of science that you need to do for, you know, having a placebo control, but also trying to make the study applicable and very humane. And I think they've done a good job with organizing it that way.
I got lost in talking about sort of the global and US disparity part about the indications for tecovirimat right now. But what I should say is that the CDC and the guidelines recommend right now that people who fit into this category, the open label, so someone who has an impaired immune system or who has severe skin disease, so someone who has like eczema or psoriasis, like a lot of broken skin where the rash could spread very quickly, or children, because we know that from other prior clades of the virus that children can be impacted, especially with neurologic disease more quickly, and people who are pregnant or someone who already presents with severe disease, that those people should just be treated outright. And that's actually who the CDC recommends treating. So as Michael said, the cool part of this study is that essentially, if you belong to a group in which you have monkeypox, clinically detected monkeypox, you have to have at least 1 lesion that's not yet crusted over within 14 days of symptoms. So if someone has that, but they don't fit into this category of the people that say, like, the CDC says you should absolutely treat these people, then those are the people that are randomized, if that makes sense. So that's kind of this balance between saying we think that people who are very high risk should get treated, but we also need to get data, and placebo-controlled studies are the best way to get data.
Yes. And we're going to go through these when we get a little bit more into the study design. But the background, as you've already learned from Rachel, you know that we're experiencing this multi-country outbreak, and we really need a treatment that is proven, not just going on anecdotal evidence. So we are lacking the safety and efficacy data for human monkeypox, and this study is designed to take care of that need. So I wanted to go the design. So it's a phase 3 study. People are randomized, placebo-controlled, double-blinded, meaning neither the person in the study nor the study team will know who is getting the drug and who is getting the placebo. The study is also going to include a cohort of people who received the open label, as we just went through, and here's the list of the people, again, written out differently. So I think that's a good sign for this. The study participants with symptomatic human monkeypox who do not meet criteria for the open label cohort will be randomized to either getting the study drug or the matching placebo for 14 days. And that'll be the 2-to-1 ratio that they're going to follow. All participants will be followed through a combination of virtual assessments, in-person visits, and daily self-reports for resolution of clinical disease, specimen collection to assess viral clearance, and participant-reported outcomes through day 57. So it's about 60 days. There's also going to be an intense sampling for a subset of people. The participants who progress to severe disease after they've been randomized, they're going to be offered open label study drug. And if those participants report severe pain from human monkeypox, they will also be offered the open label arm as early as 5 days after their randomization. And the primary endpoint is time to clinical resolution, which they defined here as all the skin lesions are either scabbed, desquamated, or healed. And desquamated means flake. So it's either scabbed over, or it's flaked over, it's healed, and all the visible mucosal lesions are healed. So the study is about 60 days, and there again is the sample size of the arms. So 530 people in arms A and B. The arm C does not have any specific size that is mentioned.
Yeah,
So-
I think the reason why the size isn't mentioned is that the idea is that that's providing open label tecovirimat. So that's the standard of care right now. And so essentially people who, when we meet them, the way we're doing this, and we've just enrolled our first person here, when we meet them, we know after they've provided informed consent and we've done an exam in history, we know which side they go into, the AB, arm AB, or whether they go into open label. The open label is exactly what they'd be getting through clinical care.
Mhm.
And so I believe the idea is that we're just going to enroll as many people as we can in arm C, while arms A and B are trying to march up to get to 530 people. And as many people as we treat, the better, not only to get more data, but also because clinical care is very tight right now. And any person we treat on this study is getting the same exact thing as if like a Madison Clinic provider or an infectious disease provider gave it to them. And so it's like unburdening the clinical system at the same time. So they're getting the exact same thing. You know, it's not often that you're on a study in which you're getting exactly clinical care, but that's what arm C is. So I think that's just some clarity, maybe a little bit around why there's no sample size. I think when we reach the sample size for the randomized part, I think they'll shut the whole study off with however many people have happened to come into arm C.
Yes. And so if you remember a few slides back, they were talking about it being dependent upon your weight, the amount of drug that you would be taking. And so you can see here how they've broken it down. Arm A would be the study drug arm, and they're getting tecovirimat at 400 milligrams when they're between 55 pounds and 88 pounds. And then from 88 pounds to 264 pounds, it's 600 milligrams. And then if you are greater than 264 pounds, you're getting 800 milligrams by mouth. You're doing it twice with food daily for 14 days. The placebo would follow that, that dosing. And then the open label also does that. Now, the open label also goes into some detail, which I didn't include here, that is specific to children. Just so you know, like there are specific weights that they'll be looking at. So because someone could be under 18 and still enroll in arm C. So I just didn't include those because I wanted to try to keep the information at bay. So who can enter this study?
I have a question.
Go ahead.
How is the mid-range weight determined with that particular dosage?
Let me go back.
That is a very broad weight range.
It is.
Broader than the prior and the after.
Yeah, I agree. I think so almost I think the take home is that 40 kilos is the lower weight range for most adult medications, and its pediatric dosing is below that. So for example, you know, my 10-year-old weighs close to 40 kilos. And so like, you know, most teens and adults, except for larger adults, will get this weight range. So I think what they figured out is that, so just think of it as really sort of a single dose range for most adults. And then it seems as though potentially based on some of the earlier studies that were done in people before the pandemic, that people needed an extra daily dose. So actually, this is not, this, we're giving people, it's actually 600 milligrams 3 times a day.
3 times.
Yeah, but it's 600, not 800. So
Like the middle one you're talking about?
Yeah, I didn't catch this. These slides came from like an earlier version of the protocol. So I think they changed the dosing. In any case, I think what they found out is that larger adults need an extra daily dose in order to based on the distribution of the medication in the body, to not underdose people who are of 120 kilos or more.
I got it.
So this is my mistake. I provided older slides that I think it was updated.
Yeah. Okay.
But, so for all intents and purposes, almost everybody gets 600 milligrams twice daily, unless you're a kid or over 120 kilos.
Let me hear you correctly. You are saying that the middle range weight of 88 pounds to 264 pounds is dosed at 600 milligrams 3 times a day for 14 days. Did I hear you correctly?
Twice a day. So that one is correct. The middle range is correct. What's incorrect is the bottom range for the higher.
It's twice daily. It should be 3 times daily.
It should be 600 milligrams. So they're getting the same dose, but 3 times a day instead of 2 times a day.
Oh, so in other words, you're saying that for those people who are over 264 pounds, they should be getting 600 milligrams 3 times a day.
Yes.
3 times a day.
Not
exactly.
Not 800 milligrams.
Yes. Right. Yes. I think, like I said, I think this was this slide that came out, this protocol, they started writing this protocol on July 21st, and the first patient was enrolled on September 6th. So
yeah. Thank you.
things were moving too quickly for their own good, I think.
I'm just asking a question to get a straight answer.
Yeah, no worries. I'm just explaining that in some cases, things were moving so fast that, making sure that we're like, I'm on the same page because it moves too fast. So that was my mistake.
Can I make the assumption that you're going to change that before you make another presentation?
Oh, yeah.
I will now.
Thank you. Because to me, it's like abysmal difference in these dosages. So I was just curious if it actually efficacious at all, and it gives the question of the study: is it effective to start with? So that's the impression I'm getting. I think that can be corrected easily. Thank you.
Yeah, absolutely.
So are you saying the lower dose, the small people are getting 400 twice a day, and the bigger people are getting 600 twice a day, and the biggest people are getting 600 3 times a day?
Right. And there are a whole bunch of other dosage regimens for the tiniest people. So we're enrolling people. Actually, when the study first came out, they said we're enrolling down to 3 kilos. There's actually no lower limit of weight. So a 10-day-old baby could be on the study. And they would get dosed appropriately. So they get much tinier doses than that. So that's why when Michael said he wanted to spare all the detail, we have, so this study is not only going through the ACTG, it's going through Impact Network, which is the Pediatric AIDS Clinical Trials Group. And in Seattle, Seattle Children's Hospital, led by Ann Melvin, was an impact site. I believe they closed at some point during the pandemic. But we've had the good fortune of having Anne agree to be an investigator with us. So if there's a chance that we find a child who's been affected by monkeypox, we will enroll the children, and we can see children and family members. So if there's a household exposure, we can sort of enroll everybody together. But we have a pediatric infectious disease specialist who's actually a pediatric HIV clinical researcher for however many years. And she will be seeing the kids, in addition to, we actually have a really amazing infectious disease fellow named Alora Karmarkar working with us. And she works at the sexual health clinic, is her primary place that she works, but she's boarded in both pediatric and adult medicine. And so we are well equipped to ethically take care of children in the study. And so like all the blood volumes and blood draws and all of those things are all adjusted for tiny people.
Right. So these are some of the things that they're looking for. The confirmed or presumptive disease. And that means either they're getting it confirmed by a laboratory or they have a presumptive diagnosis. And that's because they're either with comparable skin or mucosal lesions or proctitis, and they've had known sexual contact with someone with human monkeypox virus within the last 21 days. And so that's what they mean by presumptive. They're just presuming that that's what it is. The onset of the symptoms of the infection have to be within 14 days prior to the randomization, and a lab diagnosis within 7 days, or on entry if it's a presumptive case. The presence of one or more select monkeypox infection symptoms within 24 hours prior to being randomized. Any severity, so it could be a mild case, it could be a severe case. It's open to everybody. And people without severe disease or high-risk individuals enter randomized double-blinded. The people who are without a severe disease or are not high risk is what it should be. Enter randomized double-blinded placebo-controlled study. The people with severe disease or high risk for progression receive the open label, as we said before. And those who have severe infection, and they define it in severe for us here, they go into detail. So you have suspected or confirmed ocular involvement, facial lesions on the malar, the nose, or the eyelid region, confluent facial lesions, hospitalization due to the infection or its complications, or you have lesions that require surgical intervention. And it goes through the type there, debridement, urinary catheterization, sigmoidoscopy, or lesions extending below the dermis. So all of those are considered severe disease. And they also define who else can be in Arm C. So they say severe immunosuppression is defined as HIV with a CD4 count below 200 copies.
And I'll add to that, actually, it now includes anybody whose viral load is greater than 1,000 on their last check. So anybody who's not currently on the ART or not taking it in a way that suppresses their virus.
Great. And you can read through this list of other people, but I liked how they gave you a severe immunosuppression definition. So it's really specific what they mean by a severe immunosuppression. It's not just anybody with HIV, in other words, being considered severe with their suppression. Oops, let me go here. And here are the other things that are considered severe: skin conditions that are going to place people at a higher risk for this dissemination of the infection, atopic dermatitis, or skin conditions like eczema, burns, impetigo, the zoster virus infection, psoriasis, I don't know what that last one, Derriere disease, keratosis, follicularis.
Me neither, Michael.
What is that? I was going to say, I don't know that one.
No, like seriously, I don't know.
Wow. Breastfeeding.
So essentially anybody who has like a full body skin disease.
Yeah. And then also pregnancy and children under 18, as we said before. So those are all the people who will be considered for the Arm C. And so the other thing that I like is that people will get compensated like this for the study. But the point I wanted to really point out was the last one, because I like what it sounds like. So people can be compensated for their time and the effort they put into the study. There's physical exams, blood tests, swabs, and the medication. All of it's provided at no cost to all participants. But this last one is not something you hear often with the study. Safe transportation and nutrition support will be provided to those in need during isolation at no cost.
Can I add the other thing that I personally, so I haven't had the experience of being in this position yet, but I've had family members in my house who've had COVID, and I've taken care of a lot of people with COVID. and taking care of a lot of people with monkeypox. And in both of those scenarios, what people find is that they get diagnosed and then they get told, stay out of medical care. Stay at home, don't go to work, don't go anywhere. And then, you know, I've had patients contact me and they're really scared. It seems to be getting worse. I'm alone. Will you look at this? Is it getting worse? Like, can somebody see me? It's getting worse. And, you know, in the same, and especially during COVID, same thing, you know, my cough is worse. I feel bad. My doctor won't see me. They told me to stay home. So honestly, I think one of the biggest benefits of being part of a study like this is that we see you all the time and video chat and all of these things. And so it, in some ways, and just like, and Clay, our research nurse, and Eli, one of our other clinicians, and hopefully me too, just like it's a lot of support and it's a lot of attention and time that we spend. And we're like totally happy to hang out with people who have this infection. Because we're prepared for it. And so that's, I think, really different than a lot of other people's experience when they are told to isolate with this virus. It can be very lonely.
And it can also be very long.
And scary, lonely and long and scary. So
Yes.
I mean, I honestly think that obviously money is money and money can be very important for some people, but I also think that the like not being alone through what can be very scary is potentially even the biggest draw.
Yeah, I agree with you. And the whole idea of nutrition support being put in there, like in other words, if you can't get food and you don't have someone to drop food off for you, you know, that can just be stressful, you know, like you're stuck. And I like how this is thinking of that, and those people will be taken care of that way as well. So this is part of one of the designs that the ACTG has designed or had designed for them. And I just threw it in here as a last minute thing here. So if anyone is interested in the study that we're doing here, they can simply call us at the number that you see there, 206-773-7129. They can call us, they can text us. We'll get right back to them. And so just to keep that in your pockets. So the questions that they want you to ask, I want to stop sharing here for one more second because I'm going to try to share this through the chat. And let me grab that. So you'll see coming through to to each of you through the chat is a document that you can download. It's the CAB protocol, and it's filled with questions that they want you to ask or answer, sorry. So do you see it? Has it gone through to you all? You should be able to download that if you click on it. It should be able to, or right click, you should be able to download.
And Michael, should we say also that we brought this, I think because, you know, so it's, they asked for protocol input as well before the protocol opened. And because this study includes people predominantly without HIV or, you know, agnostic to HIV status, we also brought this to the VTU CAB, the Vaccine Trials Unit, that has a pretty diverse CAB made up of people with and without HIV. And because Michael was on leave, also they were very kind. Ro was very kind to facilitate that discussion, and we obtained formal feedback that way. I wish that we could have brought it to this group before we opened the study, but fate didn't allow that to happen. So my apologies on not doing things in the usual and customary order.
Right. And I just want to point out to you all, these questions you could answer on that form that I just put into the chat. And in fact, you could send that form to me if you want, and I can send it on for you. Or if you want, there's at the top, the two names. You'll see Danielle Campbell is one of them. They want to get them directly from you guys. And so usually we go through this as a discussion item, but I wanted to make sure that you understood that you could fill that out to get that in, especially if you wanted to write any sort of suggestions for the last question for the study. But we can do this verbally like we have done before. Did you guys understand the study?
Yes.
Yes.
Yes, cool. And do you think this study is answering an important question? Now, they say here for the HIV community, but I think it's asking for a larger community there, but we can just keep it for the HIV community. Do you think it's answering an important question?
Yes.
Yes.
Cool. And if qualified, would you participate in this study?
I would say yes. I think it's really nice that the study is, if you have severe disease, if it's defined right, then you get treated.
Mhm.
So I think, and I think that that's a real benefit. And if you don't have severe disease, then I think you can help us figure out whether this treatment is a good one or not.
Right. And, you know, I could see people being worried about being in a placebo arm and that making your infection get worse because it's just a placebo. But it is nice. I like that you can be put into that open label. I don't know if the 5-day wait, how that would appeal to people. You know, like what they were suggesting, that people like could go into the other label after 5 days if they had increased pain or severity of their disease. Who knows? Like, but would you recommend this to other people to qualify?
Well, a thought just occurred to me
Go ahead.
that they didn't discuss any exemptions, people who cannot participate. So I'm guessing that there aren't any exemptions.
There are no exemptions other than someone whose infection is like somebody's rash has completely crusted over. So if they're already past the phase where they kind of have active lesions, and if there's someone who is on a medication that is thought to strongly interact with it, where it would be dangerous to them for that reason. On the flip side, anybody who is on, for example, an HIV protease inhibitor, where the thought is that the protease inhibitor wouldn't be harmed by the use of tecovirimat, but the protease inhibitor like a ritonavir or actually a cobicistat as a booster could boost the levels of tecovirimat. So it wouldn't harm somebody's HIV treatment, but it could have an effect the other way. All of those people are actually requested to go into the open label arm and enroll in. There's another like component to this where they do intensive pharmacokinetic sampling, meaning testing, having somebody take the pill in front of us in the clinic and then test their blood at 1 hour, 2 hours, 4 hours, 6 hours, 8 hours, and 10 hours. So it's a long day, but it's just one day. But the whole reason is to try to get more data, for example, on people who are taking cobicistat or ritonavir or tacrolimus or something like that that might interact with the medication. But only if that is felt that the effect would be on that medication affecting TPOXX. If it's thought that it's TPOXX affects the medication, which is not really thought to be a strong concern, and it would be a safety concern for those people, then those are the only people that I think are not allowed on the study. But yeah, it's the idea is that any single person who has active monkeypox disease should be able to be on this study, and it's just to figure out whether they belong in arm A or B or arm C.
Right. And Rachel, when you were first telling me about the study, you were saying that this study is really going to promote access to this drug for people. Like we're going to make it more available to people through this study. And I thought that was a good enough reason that people might want to participate.
Yeah. I'd say here in Seattle, we actually have really good access if you know how to get into public health clinic, the sexual health clinic, or UW. But for example, Country Doc isn't prescribing. I think Polyclinic and Swedish are referring their patients to the UW. So for people who are from those places, I know Multicare in the South End in Tacoma is prescribing. But if people, you know, are diagnosed at other places that they don't belong to a healthcare center, I don't actually know if CMAR is prescribing or not. But we're reaching out to all of those places, specifically the places that we know are not prescribing tecovirimat. And the reason why people wouldn't be prescribing it is because it's a CDC program. You have to register with the CDC, and it's about 2 hours of paperwork per person that you put on tecovirimat for the provider. So it's hard. And so some people just aren't doing it. it's easier, like once your institution does it, it's easier to do it. Again, I'm talking about outside the study, but so since UW decided to do it, UW is currently trying to provide treatment access to a lot of people around the Puget Sound, and we can't reach everybody. And then, for example, in New York, what I'm hearing in New York is they're not treating everybody with monkeypox. They're only treating people who meet the high risk severity criteria. And because of that, some of the people who have less severe disease might not be offered treatment unless they were on the study. So it's an option for like somebody who only has 1 or 2 lesions, who their doctor says, you're probably fine. I don't think we should give you this medication. They could enroll in the study and they can see if they get the medication or not. And they could also help figure out if it's beneficial.
Right.
Not only for them, but also some of the questions being answered by the study, and I don't think we talked about this, Michael, as well, are they're actually doing culture of the lesions and of genital swabs and things. So it's not just is there DNA of the virus there, but looking to see, can you grow the virus? And that's not exactly looking to see if that's transmitted, but it's looking to see if it's transmissible. So part of the big question to answer for this is like, maybe because the case fatality rate isn't that high, not that many people are being hospitalized, not that many people are getting really, really sick, but it would be totally worth it to treat people as a public health measure, right? If it would prevent other people from getting infected, number one. And number two, if somebody's lesions went away faster and they could come out of quarantine faster, right now some people are in quarantine for a whole month. I should say isolation. Sometimes people are in isolation for a whole month. What if people didn't have to be in isolation for a whole month? What if people could get back to work and get back to doing what they wanted to do much faster? That would be entirely worth it.
Yes, indeed. So the last 2 questions, I think, are the interesting ones. Do you see anything in this study that's going to discourage a specific group, whether it's women or men or people of color or people under 18 or people over 50, IV drug users, you name it? Is there anything that you see in this study that's making them less likely to enroll into this study? And do you have any suggestions for changes to the study?
I would like to make a suggestion that with your last question, not this one, would you recommend anybody to enter the study? Sure. I would qualify that question or answer by not giving an answer yes or no, but instead recommend everybody, if at all possible, because once the individual discover the spectrum of coverage in this study, like Rachel just explained, that you explained very well, that individuals will have a better understanding and be able to ask the questions appropriate to their individual participation to make that decision. That would be very helpful. This particular study is quite different than many other types of HIV-related study, which I think that it is very good to cover as many population, as many communities as possible. This is more or less, to me, like a smallpox pandemic in the old days. So when this is being covered, I think that many other researchers along the same line will be better serve the community in the health field. That's what I have to say.
Thank you.
And I want to say also, I think that we as HIV researchers who are now doing this study benefited so much from community advocates. I didn't design this study. I'm not on the leadership team from this study, but I'm on the leadership team for some of the big NIH COVID studies. And I know that the same thing happened, is that when people said, oh no, again, just sort of the same thing that Bill was expressing at the beginning, that people really listened to the fact that, women, breastfeeding people, pregnant people, and children were really excluded from a lot of early HIV studies. And it was the HIV advocacy community that spoke very loudly and clearly for COVID studies and said, no, don't exclude these populations just because you don't know whether it's, it's safe yet. in some, because for those COVID studies, in many cases, it was the only way to get treatment. And so why don't you leave it up to the pregnant person to understand the risks and benefits and decide whether or not that's something that they want to do, instead of just excluding them sort of like from a paternalistic standpoint. I don't know how well that worked for the COVID studies. Some of the COVID studies are very exclusionary of people who are pregnant or of minors, for example. But I think they heard the message loud and clear for this study and said, this study is treatment. It is the standard of care. We're giving it to people. We have some safety data in adults. And the best way to find out whether these vulnerable populations should be taking this medication is to study it. And everybody can be educated and go through informed consent and make their own decision about what's right for their body. And we shouldn't be excluding people. And I really think that comes with so much gratitude from HIV community advocates who spoke up over the last 40 years.
So that's our study. And I wanted to end here because the questions that we have, I really think we need to get more of our CAB to get good answers and get a good discussion going with that. So I wanted to just keep off for those questions for right now. And because it's 7 o'clock anyway, and I wanted to make sure that we didn't go too much over time. But I wanted to ask if anyone has any questions. And I know, Bill, you have to leave soon, so we're gonna sign off here. Any final questions you wanted to ask while we have time?
Well, Michael, did you get the feedback you need from us, or did you want us to fill out this form?
If you want to fill out that form, and
well,
you can,
I looked like something I could type in, but I can't.
You can't type in? Is that what you
No.
said? If you
I
want,
can't do anything with it. I can print it out and write on it, but
okay, but you can't write. It should be usable. Let me see.
well, I don't know. It was the thing it said, you know.
I will try to send it to you via email.
Okay.
Okay, let's see if we can get it to you that way. Maybe it's just when it goes through the chat, it didn't come through. Does anyone else have that problem, that you couldn't open it and couldn't write on it? Because it's supposed to be designed that you can type right into it.
I couldn't download it.
Okay, I'll send it to you via email to make sure.
Send it to everybody by email because I didn't get it.
Okay.
Yeah, I got it, but you
I'll
can't
take care
type
of it.
into it.
Yeah, no worries. I'll take care of it that way. So I'll send everyone here an email. Let me make
Technology.
Yes. Yeah, technology indeed. All right. Well, I want to thank you all for taking time out of your day to help us with the study, getting familiar with it yourselves and becoming knowledgeable about it, and also giving us the reflections that you have about not only monkeypox, but the specifics of the study that struck you. If you have any questions after today, please don't hesitate. You can ask them right to me if you want, and I can make sure I can get them to Rachel, and we can get answers for you very quickly that way. I'm just thankful that you were all around and that you all got to come here. And I hope that you are feeling the beginning of fall is a bracing and beautiful time for you, because it's a nice time for me.
And it's nice to have you back.
In Indian summer.
It's nice to be back there. Yeah. All right. So let's say goodbye, and we will meet next month, which is Tuesday, October 25th, and I'll send out the email when we get closer to that date. All right. Thank you, Rachel, for helping us with the study. Thank you, Anne. Thank you, Larry. Thank you, Bill.
Bye, Anne.
Bye, Larry and Bill.
Thank you, Jen. You left, though. All right. Take care.